Optimal pharmacotherapy. So we come up with these good ideas based on the discussion and questions that you bring up. Not always as easy as it looks. So the objectives for today, we're going to describe some of the medication options for treatment of schizoaffective disorder and then compare some of the data. Although you'll see the data that we're looking at is really difficult to be able to compare. In full disclosure, we are talking off-label today. So we do have one agent that is FDA approved. So Paliperidone is FDA approved for acute treatment of schizoaffective disorder, both as monotherapy as well as adjunctive therapy. So almost a teaser, we're really going to be focused on antipsychotics, mood stabilizers. We're not going to spend as much time on antidepressants just due to lack of time today. What I wanted to do with this, so a question had come up last time about what about the duration of untreated schizoaffective disorder? So with conditions such as schizophrenia, we are relatively sensitive to the duration of untreated psychosis. So we tend to have a clear link in duration of untreated psychosis and functional outcomes for our patients. I was not able to find a very good correlation for patients with schizoaffective disorder. There is a small percentage of patients who are not on pharmacotherapy currently, but it seems that a large number of them end up with, have been on treatment previously and then potentially progress into their diagnosis of schizoaffective disorder, or they have a number of other medications that are already on board before the diagnostic criteria gets clarified. So it isn't well reported out in the literature, the amount of patients with schizoaffective disorder that just aren't treated and what happens to them. They tend to get to this place kind of via a different route. So I wanted to make sure that as we were looking at this, we were looking exclusively at patients with schizoaffective disorder. So there is a lot more literature available, especially in the acute treatment of schizoaffective disorder, but it tends to be under the umbrella of psychotic disorder. So schizophrenia, schizoaffective disorder, general psychosis. So the literature that we're going to look at today is going to be those that were specific for patients that were diagnosed with schizoaffective disorder. So with that in mind, we had our teaser before that might have spoiled it a little bit, but these really are our big classes of medications that have been used for the treatment of schizoaffective disorder. We're going to spend most of our time looking at the literature related to antipsychotics and mood stabilizers. Antidepressants have been used in patients. There's not a lot of literature specifically looking at antidepressants alone in schizoaffective disorder or in patients who just have this. It tends to be antidepressants added to an antipsychotic for overall psychotic disorder. And because I really wanted to focus on this diagnosis, we don't have too much in the way of that for today. So what is this going to look like? I know that when I was at the state hospital, when I was at the community mental health clinic, the patients who had schizoaffective disorder, at least the patients I was caring for, tended to have really complicated medication regimens. So they didn't tend to be on something that was relatively straightforward unless they had fallen out of care and then came back and ended up only on usually a long-acting injectable because the thought was they hadn't been adherent. So I tended to see patients on a lot of different medications. So I was glad to come across this. So it was a retrospective exploratory analysis that was conducted looking at the treatment of patients in outpatient clinics in Germany. So they reviewed adult patients with a diagnosis, and full disclosure, they included schizophrenia, schizoaffective disorder, and bipolar disorder. But I just included the information for the schizoaffective disorder for this presentation. So they had 101 patients that they followed. They excluded any patient that had multiple diagnoses. So even though there were quite a few more that had schizoaffective disorder, but they also had a diagnosis of bipolar disorder or schizophrenia or multiple other mental illnesses. So this was only those with schizoaffective disorder. So take that into consideration. But when they looked at these patients, they found that just over 10% were on antipsychotic monotherapy. Just under 15%, so 13.95%, were on combination antipsychotic medications, and that could have been long-acting or oral medications. More than half of them were on combinations of antipsychotic medications, both first or second generation, and a mood stabilizer. And then about 6% of the patients were on antipsychotics, mood stabilizers, and an antidepressant. So really the vast majority of the patients, more than 3/4 of them, were on multiple agents. As we look at the literature, we're going to see that most of the information that we have specific to this population is a little bit more with monotherapy with some adjunctive treatment thrown in. As I had mentioned, our Paliperidone, so the folks at Janssen were actually relatively forward thinking as they developed the Paliperidone and going after this indication because there hadn't been another agent that was officially approved for it. So the trials that got Paliperidone the approval for schizoaffective disorder, there were 2 of them, randomized double-blind placebo-controlled 6-week trials, both with just over 200 patients. Most of them were adults. They tended to be in their between 20 and 40 years old. The first trial allowed for flexible dosing. The second trial allowed for fixed dosing, so 6 milligrams or 12 milligrams, but they could reduce the dose if the patients had side effects. So they could go down to 3 milligrams if they were in the 6 milligram group, or they could go down to 9 milligrams if they were in the 12 milligram group. For the first trial, that group that was able to do the flex dose, the average dose was just under 9 milligrams. So they really were using a pretty decent dose of the Paliperidone. Interestingly, compared to placebo, they saw statistically significant improvement in all symptom domains. So psychotic symptoms, in mania, in depression. They didn't necessarily look at changes in hospitalizations or time to relapse because these were relatively short term. But across the board, both for the mood symptoms and the psychotic symptoms, they saw improvement. And the reason that I make this distinction is there's a couple different subtypes of the schizoaffective disorder. And we'll see with some of the other treatments that potentially some of the agents may work a little bit better for some of the symptom domains than with others. But across the board, at least for Paliperidone, it showed pretty uniform efficacy. Adherence is noted to be problematic for patients with schizoaffective disorder. So upwards of 60% of patients have been noted to not continue to be adherent long-term in their treatment. So there has been a look at trying to use long-acting injectables. So this was one of the trials. It was a randomized double-blind placebo-controlled trial. And this was for relapse prevention. And it was a continuation trial. So there was 13 weeks of flexible dosing, and then 12 weeks of patients had to be on a stable dose. So by the time they got to the relapse prevention trial, it had really been about 6 months that patients had been on Paliperidone. So these were just the patients who had responded. So those who were doing relatively well with the Paliperidone. They were mainly on the higher doses, so about 47% were on the 156 milligram, and just under 40% were on the 234 milligram dose. So most of the patients did require those higher injections of the monthly Paliperidone. There were over 300 patients, and they were randomized either to the Paliperidone or to placebo monthly. What they found was that the risk of relapse was 2.5 times higher with placebo than what it was with Paliperidone. So patients were much more likely, so 61% of the patients completed the trial in paliperidone. They tended to like it better. They had lower relapse total number of relapses. They had, so the 18%, the green bar there, is for patients that were on adjunctive therapy. So they may have needed additional antipsychotic treatment or mood stabilizers. So they were able to use both. The purple bar is those that relapsed that were on monotherapy. And interestingly, for paliperidone, there was a lower percentage of those that relapsed on monotherapy. So if they had been responding at 6 months, they tended to do relatively well over the next 15 months on the paliperidone monthly injection. If they needed a booster, they were at a little bit of a higher risk for going on for relapse prevention, or going on to relapse and require hospitalization. In the placebo group, they were pretty consistent. So about a third of all of the patients ended up having a relapse and requiring hospitalization. So suggesting potentially that patients who aren't on stable treatment may go on to relapse. But I do want to point out that green bar is adjunctive. So it means that there was a placebo injection with some other type of treatment. So whether that be an oral antipsychotic, an oral mood stabilizer, they had the potential to be on something else, and it was still about a third of those patients. So it looks like if they had responded to the injection, they might do better in not having a relapse if they continue with that injection. So what about our other antipsychotic medications? So there was a trial done a while ago now that looked at risperidone and haloperidol. It was randomized, double-blind, active comparator trial short-term. So this was only 6 weeks. Patients could use up to 10 milligrams of risperidone and up to 20 milligrams of the haloperidol. They looked again at both psychotic symptoms, depressive symptoms, and manic symptoms. And they found really no difference between the two groups, with the exception of depression, and we're going to come back and talk about that in just a second. So overall, the patients had significant reduction, so by 14 and 16 points in their PANSS score. So most of the patients started in the mid-80s, so they did have moderate psychotic symptoms to start with, and they all did show significant improvement. The mania rating scales showed a greater rating scale reduction with the haloperidol, but there still was a significant reduction with the risperidone. So maybe it wasn't quite as potent for the mania, but statistically there weren't enough patients to be able to tell the difference. On depression, it was a little bit different. For patients that had higher depression rating scores, they tended to do better with the risperidone, and that's why you see there was a 13-point reduction in the HAM-D for those patients on risperidone. With that in mind, even though there wasn't statistically a difference between those two groups, when they looked at the subgroups, if patients scored more than a 20 at baseline on the HAM-D, they're the ones that had the greatest reduction in the Hamilton Depression Rating Scale on risperidone. So they tended to do a little bit better. So possibly having that patient population that has more depressive symptoms, possibly they could do a bit better with the risperidone. There were, from a tolerability perspective, most of the discontinuations were just from patients refusing to continue. They revoked their consent. There were more side effects, so there were more metabolic adverse effects, including weight gain with the risperidone, and there were more movement disorders that were seen with the haloperidol than with the risperidone. But that didn't look to be the main driver for discontinuation of therapy, although it was only 6 weeks in duration. So they looked to be about equally effective. Aripiprazole also had some information specific to schizoaffective disorder. So they actually pulled this data from the general psychosis trials that they'd done with aripiprazole. So they kind of drilled into the bigger randomized controlled trials and just pulled out the patients that had this diagnosis. There were 123 patients that were on aripiprazole and only 56 that were on placebo. So again, they weren't randomized to be equal here. It was just kind of looking at this subgroup from the larger pool of data. And what they found was that significantly across the board for the psychotic symptoms, the aripiprazole did show improvement. So for the total PAN score, as well as the positive and negative symptom scores, aripiprazole had an improvement for these patients. There were some changes related to mood symptoms, so depression as well as mania, but they didn't see a statistically significant difference between the groups. So there could be a bit of a difference, but it looked like the aripiprazole in general had a little bit of a better improvement for the psychotic symptoms. Now I'm going to say that with a word of caution, because this was from a general psychosis population. So they were looking at changes in psychotic symptoms as their primary endpoint. So maybe they just didn't include a lot of patients that had any type of mood disorders. So I don't want to completely discount aripiprazole's ability to treat the mood symptoms. It really just wasn't, it didn't show up here, but it wasn't a focus of their trial. So better than placebo, especially for psychosis. The mood stuff is still a little up in the air. There are a couple other trials, so related to the antipsychotics. So Ziprasidone has a couple small trials that look at schizoaffective disorder. Olanzapine has a little bit of data there too. A lot of it though really comes from pulling from that pooled analysis. So you have patients with schizophrenia or schizoaffective disorder with psychotic symptoms that are on antipsychotics. They see improvement, but it's not incredibly clear that it's improvement in all of the symptom domains. So recognizing that they were really focused on psychosis, I was like, well, let's look at the mood stabilizers and see if we can see what it looks like on the mood side. So for this trial, it was adult patients with schizoaffective disorder, and they had to be on maintenance treatment. So they were doing well, they were outpatient, and they had to have been on a stable dose of either, and they could be on anything, but lithium and carbamazepine were the two main ones that they found, for at least 3 months. So these patients were then just followed for as long as they were in treatment in the outpatient treatment center. During this period of time, so they were followed for just under 7 years, although one patient was only followed for a couple months, and then there was one patient that was followed for almost 29 years. So there was a huge amount of variability. During that 7-year time frame, while all patients were only on lithium and carbamazepine to start with, a third of them did require additional treatment with antipsychotic medications. And 10% of the patients ended up on both an antipsychotic and an antidepressant. Now, it took about 3 to 4 years for them to require additional treatment. So patients did well on their monotherapy and then needed something a few years down the road, so between 3 and 4 years. Their main outcome was looking at time to first recurrence. So the average time to first recurrence of symptoms was about 2.5 years after starting maintenance treatment, which I thought was interesting because the general time frame, the average time frame for starting new medications was 3 to 4 years later. So first recurrence popped up a little bit earlier than the additional treatment, starting to use combination therapy did. But there was a significant improvement. So in looking at their changes in hospitalization from before they were started on their maintenance treatment to after they were started on either the lithium or the carbamazepine, they saw a significant reduction in days that the patients were hospitalized. So it went from an average of 71 days a year to 11. And the number of hospitalizations a year went from almost 4.5 down to just over 1. So they did see that even patients that are just on monotherapy of the lithium and carbamazepine were able to continue and do relatively well. What about other mood stabilizers? So divalproex was the other one where I was able to find a little bit more data specific to schizoaffective disorder. So this was a retrospective trial in an outpatient clinic. There were only 20 patients, and the average dose of divalproex that they were on, as you can see, there was just over 1,100 milligrams daily, and their average serum concentration was just over 60. About 75% of the patients were shown to have been improved on the divalproex. None of them had a recurrence of symptoms, and none of them discontinued due to adverse effects. So even though there were adverse effects that were reported, it didn't result in discontinuation, and it was something that was considered tolerable. Now, the improvement was reported based on the clinical global impression of severity. So it wasn't done necessarily based on the rating scores. But at baseline, the patients had psychotic symptoms as well as mood symptoms, both mania symptoms and depression symptoms. And overall, there was a reported improvement for those patients. So it didn't look like it only targeted patients with predominantly mood symptoms. And lastly, I was able to, so some of these are much older trials. So I wasn't able to get all of the information that I wanted, but I was able to find a little bit more related to mood stabilizers. So while I'm showing you, yes, it looks like it's better. Yes, it looks like it improves. That's probably not the whole story. So there were 2 other trials looking at lithium that were 2 years in duration, and both of them showed that with monotherapy of lithium, patients did well. They decreased the number of mood episodes that they had and also decreased the number of hospitalizations. There was one other trial that was a year in length that looked at lithium plus chlorpromazine compared to placebo. They did not find a difference. And I believe it was lithium plus placebo and chlorpromazine plus placebo were the different groups. They did not see a significant difference in symptoms between those groups. So lithium monotherapy versus the combination didn't look like it provided any additional advantage for those patients. Carbamazepine also had a couple other trials. So the first one was only 4 weeks, so short-term in duration, but they did see a significant improvement. So about 40% improvement in mood symptoms. And then there was also a trial looking at carbamazepine in conjunction with antipsychotics, both first and second generation, that lasted for a month. And that one did not show any improvement in symptoms compared to just carbamazepine plus placebo or antipsychotic plus placebo. So take home from this is there looks to be a population that will respond very well to monotherapy, even though that doesn't tend to be what we're using, either antipsychotics or mood stabilizers. And if we are using combination therapy, it might be important to ensure that we're getting additional benefit because we're not consistently seeing it when we do have those combinations together. So just in summary, we do use pharmacotherapy predominantly for the treatment of schizoaffective disorder. We don't have a clear consensus. So obviously Paliperidone is FDA approved. That tends to be first line. But after that, there is quite a bit of variability. And while maybe antipsychotics should be used for psychotic symptoms, some of them have shown improvement for mood symptoms and vice versa for the mood stabilizers that have shown some improvement for psychotic symptoms. So we may not just be able to put those patients in discrete little silos. Combination therapy is often used, although the literature doesn't necessarily robustly, consistently support that there is an advantage of using combinations in this patient population. And long-term adherence does continue to be problematic. So something that we need to keep in mind. So whatever's working for the patient, we want to make sure that we're able to keep them on, especially if they're able to tolerate it.